morning?
Thank you.
Hello, hello. Charl,
Hello,
are you
hello.
ready for us? Would you like to start chatting?
Anytime you're ready, you tell me when you've got most of the people on board.
Yeah, I think it's just past 10, so we can start, and I'll just let people in as they go, and they can carry on.
Sure.
So welcome. Thank you very, very much for joining us this morning.
You're most welcome. Thanks for the invite, and morning to everybody, and very happy to chat. The brief that I got for the conversation this morning was quite wide. It was about 4.5 million questions relating to COVID-19, vaccines, immunology, safety and chemotherapy, etc. So, I can chat essentially to all of those. I thought rather than doing death by PowerPoint, because it's quite difficult to get slides to match all of those questions, it might be easier for the participants literally to sort of question as we go, almost do it as a Q&A.
Yeah.
People are welcome to interrupt, raise a hand, ask a verbal question, but it might be easier for everyone else if people type the question into the chat box. Okay, so on this, for those of you that aren't Zoomers, you've got to go to the chat section and then just type your question in there, and then everyone can see your question. And then I'll tackle those questions kind of one by one. And if we run dry of questions, then Louise and you guys must just put in kind of generic questions that you think everyone would probably appreciate to hear.
Absolutely.
Okay, something like that, right. Why am I talking to you today as opposed to anyone else? I have absolutely no idea. I think I was one of those doctors who had a gap in his diary on a Saturday morning. I am already 5 espressos down, so that's good going. And my world is emergency medicine, by the way, not specifically cancer medicine or anything else, but emergency medicine is quite useful because we get to see kind of the sharp end of all sorts of medical cases. So quite comfortable to chat to any of the topics. And also as part of my day job, extensively involved with the vaccine rollout that's going on in South Africa. We hope in the next week or so, first wave. So that'll be quite nice. I suppose the logical place to start, really, while we wait for specific questions to pop up, is to kind of see where we're going with this COVID-19 coronavirus story, generally speaking, and then try and zone it in on cancer patients specifically, if there is any zoning that we can do, whether they're survivors or current disease processes on the go, and then maybe move into the vaccine world. Just because it's topical, really. Okay. So, and also without knowing how many people in the audience have got PhDs in medicine, it's always quite difficult to pick kind of how much do we have to explain or not. Okay, so if I explain something that you know already, then just look bored and roll your eyeballs and we'll move on. Or if it looks complicated and I'm using words that sound like they belong in some dictionary, then just like ask a question and we kind of make the words, I can fit them on the screen. Where's my camera? So we can make the words like so or like so. Ne? Okay. Right. So COVID-19 is not a virus, it's a disease. Okay. So COVID-19 is the disease. It's caused by a coronavirus. All right. And that coronavirus has got a bunch of names. The fancy one is SARS-CoV-2, which is useful to be able to say at tea time. SARS-CoV-2 is a coronavirus that emerged in 2019, which is why the disease was called COVID-19, okay? And it emerged, not really surprisingly, because we've seen a lot of coronaviruses on planet Earth over the last many years, all right? So coronaviruses are not new. Coronaviruses cause a disease that's vaguely similar to the common cold, right? And the common cold is called that because it's common, and there are a lot of viruses that cause a disease that looks like a cold. Other ones, respiratory syncytial, a bunch of other viruses can cause something that looks like a cold, but a coronavirus certainly can. It can also cause disease that's a bit more severe than a cold, which is why the whole world got excited about this particular coronavirus. we've had them before. If we go back maybe 10 odd years to the MERS outbreak, MERS was another coronavirus. It stood for it's a Middle Eastern virus. Go back another 10 years behind that one, and we had SARS, the first outbreak, which was another coronavirus. And each of those outbreaks, when they transmitted through communities, caused the viral disease similar to what we're seeing now, which is COVID-19. Okay. The world didn't get quite as excited about the other outbreaks, mostly because far fewer people got affected by them. All right. So those outbreaks were transmitted somewhat slower. The virus was slightly less transmissible, and that's an invented word, in communities. And therefore, the number of people that got sick, in other words, if you've got a cold, how many other people can you make sick? Normally with these kind of viruses, it's about 1 or 2. All right, so we've got fancy numbers that describe that. They're called R0s and a bunch of other things. But what it means is that if you've got this particular cold virus, the chances of making at least 1 or 2 other people sick are pretty good. All right, that's normal for a coronavirus. To give you a different example, measles, for example, which is another viral infection. Measles has got a much higher attack rate. If you've got 1 person sick with measles, they're probably going to spread it to another 18 or 19 people, okay, compared to 2 for a coronavirus. That's back to the old school. So when you were at school and your child or you had measles, you were whipped out of school because the chances of you giving it to every single other person in the class were pretty good. So measles is a good example of a high attack, in other words, a highly infectious virus. Okay, I see the one question up from Nicole. I'm going to come to that shortly. So let's just kind of wrap up on that sort of generic coronavirus story. So the virus is currently circulating the world, part of the challenge is the fact that so many people are exposed to a novel virus all at the same time. So it's not that more people necessarily are going to get sick, needing hospital, or potentially die from the virus. It's just that all of the sickies are getting sick at the same time because it's arriving at the same time everywhere, right? So the hospital that can handle 10 or 20 or 100 patients can't handle 100 or 200 or 1,000 patients. It's not because the disease is more challenging, it's because the numbers are challenging. So in principle, it's a numbers game. Let me shoot over to Nicole's question quickly because it'll help focus the interest of what you guys are after. So 2 positive PCR tests, negative in between, totally asymptomatic, antibody test negative. Percentage false positive. Okay, so the question really talks around, a great question, around the accuracy of the tests, right? The current tests. So currently the gold standard, as you correctly put in there, is a PCR test, which stands for polymerase chain reaction, which is actually irrelevant here. It just means it's the most accurate test that we've got, right? And it's a test that's testing for specific genetic material in the virus. So it's an active, we're testing for tiny little viral fragments, if you like, right? Compared to an antibody test, which is testing exactly what it's telling you. It's testing you to see if you've got antibodies to the infection, and you would have built them up if you had been exposed to that COVID-19 infection, right? So how accurate are the tests? In terms of PCR tests, extremely accurate. Are they 100% accurate? No. And that's just a function of medical science. Medical science, those tests, the way the test is conducted is it's almost impossible to make them completely 100% because the viral fragments can be missed. Very often, it's a function of how diligently the test was conducted. In other words, did the swab actually get just the right amount of respiratory material, cellular material, in order to pick up the viral fragments? Where in the person's infection were they? Because in certain stages of the infection, you have a higher, what we call viral load. So in other words, your cells are shedding more virus in that period of the infection, whereas right at the beginning and down towards the tail end, your viral load goes down. You may still have symptoms or not, but the ability of the test to pick up the viral load is reduced. So we can get false negatives. Percentage false negatives very low, measured in the point something percent to PCR, compared to false negatives in the rapid tests, a bit more. So maybe 10 or 15% false test results in those, 10 or 15% in terms of the accuracy. So I think that talks to most of Nicole's questions. It still remains the most accurate option we've got. A PCR test still gives us the best answer. And remember that the tests that are currently in play are largely around the public health phenomenon of COVID-19. We're not, medically speaking, we're not too fussed whether you get COVID or not, because we will treat you and you will come to hospital and people will get sorted out. And most people, 8 out of 10 people, will be asymptomatic or well enough to manage at home like they've had a cold, right? But the tests, in terms of making them accurate, are important in the healthcare world, because when you come into the hospital environment, maybe you're coming in for something else, it's good to know whether you are potentially going to share your COVID with somebody else, in which case we need to put you in one part of the hospital, or do we need to protect you from getting COVID from somebody else, in which case we need to put you in another part of the hospital. Okay. From another Nicole, please talk about Ivamekton. I can't talk about Ivamekton because I'm not a vet. Is the short answer. Okay, so Ivamekton, let's not be too facetious. What is it? It's been around forever. It's an anti-parasitic drug, quite a simple drug. It's used to treat a number of worm and parasite infections in animals. It's been used for many, many years. It's been used experimentally in humans for the same thing, by the way. So they've used it in 1 or 2 weird locations to try and treat the same or other parasite infections, right? So also different kinds of worms and other funny bugs. How did someone connect Ivamekton to COVID-19, a viral infection, is a very long conversation which takes more than 1 cup of tea, né? But we'll try. So Ivamekton, as an antiparasitic, has certain side effects in the body, in a similar way to a drug that got onto our radar last year called hydroxychloroquine, which has also got an antiparasitic effect. And all the bright people jumped on the bandwagon. Everyone started taking it for prophylaxis because someone said that it would help reduce the severity of COVID-19 infections, right? That data just never, ever got proven. And the same currently applies to Ivamekton, by the way. So the short answer is, currently as we stand, there is no scientific data supporting the use of Ivamekton in COVID-19 human cases. All right. There's a huge amount of pressure in the medical fraternity to utilize drugs that may have some kind of side stream benefit for the disease, right? So people are arguing from a non-medical science perspective, but maybe just some logic, saying, well, if the drug has got some anti-inflammatory effects and it might reduce the severity of illness, isn't it worth trying it? Okay. And one appreciates the question, but there are a lot of other potential side effects to utilizing drugs that aren't tested by the manufacturers in that particular channel of treatment. So currently in South Africa, it's not a registered human drug for use in COVID-19. So you can't go to your doctor and ask for Ivamekton, and your doctor shouldn't be prescribing it, quite frankly, because there's not good data to support it right now. There is currently a very hot debate around what we call Section 21, or special, it's sort of special use permission, if you like. And on individual basis, doctors are applying for permission to use Ivamekton in certain cases, and they may or may not get permission from the regulatory authorities to do that. In a way, what they're doing is very small clinical trials. Okay, so when they're applying for permission to use a drug in those circumstances, they need to do it in a very clear and transparent way with their patients. Make sure that everyone understands that this is for experimental use, essentially what we call off-label use. That wasn't what the manufacturer thought it would be used for. And the patient has to understand that there might be side effects, no effect, other effects that weren't predicated based on the fact that it's used for something it wasn't supposed to be. And the doctor is knowingly doing this with the patient's permission. So we'll probably see over time certain individual cases coming forward where people have tried to use it. Personally, from my point of view, I don't think we've got enough good clinical information to support it. And I think we're going to wait for the clinical trials that are already underway in various parts of the world to see whether it has any potential disease modifying effect. It's fairly likely that we're going to get a global benefit from a vaccine far sooner than a benefit from the side effect of some anti-inflammatory agent that is currently out there. So I think the vaccine is a far more interesting and far more relevant medication on the horizon right now. The vaccine probably is a useful topic to talk about. I'm not sure if that's going to be a question that people are likely to ask, but I'm happy to talk about vaccines in a way because it's a good sort of segue from general treatment. And just to remind anyone that's joined us, please put your question into the chat box if you've got something that's relevant, because otherwise I'm just going to wander my way through the world of COVID and vaccines, and I might not get to the specific question that you were thinking I might get to. So you have to focus my attention on with a specific question. So vaccines. We like vaccines. Let's start there. Okay. So for those of you that are the anti-vax types, because I think there might be one or two of you lurking out there, you can just quietly shift to the background and keep your camera off so that I don't identify you and embarrass you. But there's no good logic, and I'm very happy to have a sensible argument with anyone that wants to have one in terms of avoiding the vaccine just because you don't think it's a good idea, right? Vaccines have got a certain contraindications in very, very specific patient cases. Yes, that's a different story altogether. But if it's a question of choice, then the general medical advice is to take the vaccine. And to take any vaccine, quite frankly. There are very few vaccines that have got a downside. Vaccines in principle don't cure or treat diseases. Vaccination, the process of getting lots of people vaccinated against a disease, that's what we're actually aiming for. Because what we're aiming for with most of the infections is to reduce either your ability to catch it or your ability to spread it. And that's what vaccines are doing. And they've very successfully gotten rid of other infections or illnesses on the planet. If we think back to the smallpox example, we've got great examples of how polio, for example, of how viruses have effectively been eliminated by vaccines. Most of the vaccines that are out there today, and they're not as many as people might think. There's, off the top of my head, still less than about 30 vaccines, 30. Of which about 25 or so are viruses and about 5 or so are bacteria. So we've got vaccines against certain bacteria. Think of, now I've got to give you an example, cholera, tetanus, those would be bacterial vaccines, but most of them are viruses. So the mumps, measles, rubella type vaccines, yellow fever, for example, which was the very first human vaccine, by the way. So human vaccines, I see the question around news talks rollout of vaccine. I'll chat to that right now. Yellow fever was in fact the first human vaccine. And it came out, around about the turn, I was going to say the turn of the century, but we've moved on. Turn of the last century, so 1900. So it's been around about 120 years, the very first vaccine. And the idea was created when Pasteur and the clever people figured out that there was a very small infectious particle, much smaller than bacteria, that was getting through people's systems. And they figured out a way of putting in a fragment of that virus to challenge the immune system to produce antibodies to that particular virus. And those antibodies then are various types, but they are used by the immune system to then fight a future infection. So the vaccines that we have today are produced in a whole bunch of different ways, and that'll allow us just now to answer one of the potential questions, which is about the safety of vaccines, specifically in cancer sufferers or survivors for that matter, or if you're taking chemotherapy, therapeutic agents. So vaccines are made in different ways. All of them are attacking the virus with a similar logic in mind. In other words, all are trying to challenge the body's immune system to produce those continually circulating and reproducible antibodies to the virus. So the vaccine is some form of immune challenge created to produce the antibodies, right? And those immune challenges could be different. So some of the current coronavirus vaccines, or what we call mRNA vaccines, very sophisticated kind of vaccine, which is a partial piece of genetic code put into certain cells to allow them to reproduce antibodies. Very clever tactic, really kind of modern science. The slightly more traditional vaccine is where we take another virus, take adenovirus. Adenovirus, there's lots of them. The one that you're maybe most familiar with, adenoviruses cause pink eye, right? So one of the adenoviruses can cause pink eye. They transmit super easily, but the labs can work with them quite well. So they take an adenovirus and they can put coronavirus fragments in it, and then they can spread it with the adenovirus and challenge the immune system that way. Sometimes we use a live form of the virus, but weakened. So kind of a mini dose of the infection. We think of the mumps, measles, rubella type vaccines. Those were originally live viruses. Or we use a killed version of the virus like we do in flu, for example, or one of the coronavirus ones. Cool, let's talk to some of these questions. News, I'm getting onto iPad 3, whoever that is. News talks about rollout of vaccine to frontline healthcare workers. When will it be available to the general public? Short answer, not a clue. It depends on when we get them all. So currently we're anticipating the first load of vaccines, which would be the Oxford AstraZeneca one, in the country now. The plane could actually have touched down, for all I know, today, tomorrow, the next day. And we understand that that's going to be about 1 million doses with another 500,000 doses to follow up. Appreciate that you need 2 doses per person to have a comprehensive vaccine. You need 1, and then anywhere between 3, 4, and 12 weeks later, you need a second or booster dose to get the proper range. Now, that 1 million plus doses will probably only just cover the first line, frontline and healthcare workers. Logic says that's a good place to start, because if we can get all the nurses and the doctors and the people working in hospitals protected against spreading coronavirus further, we can allow them all to work effectively, so that they're not all at risk of being at home sick, number one. But number two, they're not the hospital environment becomes a much safer environment, because we are effectively creating a COVID-free environment from a work point of view, so we can then manage all of the other cases. When will the general public ones be available? The real answer is it depends on when the next batches of doses come into the country from the same Oxford AstraZeneca one, or when the second and or third vaccines are registered and available for delivery to South Africa. So it's likely that within the next 6 months, we're going to have more than one vaccine available in South Africa, and you'll be able to get any one of those. Let's talk I'm just going to go down the questions in order. Wendy asked something about the specific risks to cancer patients and survivors, and that's a great question, and any additional preventative measures. Okay, so good question, difficult question. The current data suggests that there's no specific contraindication for cancer survivors or even chemotherapy patients, active treatment patients, to avoid the vaccines, okay? The rationale behind that is that vaccines are affording a protection to patients that are otherwise immune challenged, right? So it's a little bit of a two-edged sword. It's the logic of, yes, your immune system is taking a hammering from your primary treatment, but because it's taking a hammering, you are more exposed potentially to other viral insults, other infectious insults. So if we can put in a protective safety net, that's actually a great idea. It's always worth an individual conversation with your physician or your oncologist, your treating doctor, around the safety of vaccines in terms of timing with your current treatment. And that's only really relevant in cases where they might be using live vaccines. So live viral vaccines, again, the examples were the mumps, measles, rubella type vaccines. Those vaccines, because of their mechanism of action, it's usually advised that they are received by patients that aren't in an active chemo zone at the time. But once your immune system has got a little bit of its own, standing on its own feet again, it's absolutely fine to take a vaccine. Does age and comorbidities have any effect on the vaccine? It's kind of the other way around. So good question from Nicole. So in terms of age and comorbidities, the vaccine will work right up and down the age spectrum, right? Okay, so generally speaking, little kids, it's not being advised at the moment, mostly because they're not particularly exposed to serious illness. Many of the kids are just bouncing through it with the asymptomatic infection. But more importantly, it's about what safety data the manufacturers have got to support the use of the vaccine. So currently, the use is right across the age spectrum. Yes, we're seeing some reports in Europe. Germany at the moment is questioning some of the safety data in older age group patients, which is a bit counterintuitive to me, to be quite honest, as a non-virology expert, because that is a significantly vulnerable population that in fact would be benefiting from the vaccine, absolutely. And I think that the logic of saying, well, the vulnerable groups are demonstrating higher levels of vaccine reactions or poorer outcomes is a little bit like using a chicken or egg argument, because that is the more vulnerable population in the first place in terms of if they get COVID-19. So, the short answer for now is that the vaccine is safe. The vaccines, plural, are safe right across the age spectrum, and you should be lining up to receive the vaccines in whatever order they arrive in the country, and you shouldn't have any concern about that. In terms of, and I think that sort of addresses the risks of the vaccine. Risks of COVID was a question, risks of getting COVID in cancer patients. No specific data there, to be honest. So when we say comorbids, we're normally talking about comorbids, meaning diseases that are currently impacting your ability to fight a viral infection, particularly an upper respiratory tract or lower respiratory tract viral infection. And the comorbids we typically refer to there are, for example, diabetes, for example, obesity, underlying autoimmune conditions. Those are the common ones when we're talking about comorbids per se. Right? Cancer sufferers are an unusual group in the sense that it very often depends where you sit in the phase of treatment. User, which brand of vaccine is the best one? The first one you can get your hands on is the answer to that. So don't read too much into the media that is putting different percentage success rates on vaccines. It's really not a helpful number, because those numbers are based on very small sample sizes, and they're based on data that is kind of a bit of a moving target. So when they put out that this vaccine is 65% effective and this vaccine is 85% effective, that is not super helpful to you as the vaccine receiver. They're all effective to a particular degree in different patients against that particular virus. And 65% or 85% is measured on fluctuating or waning antibody levels and a particular stage in the disease of that particular individual. So quite frankly, and very, very honestly, if you speak to any healthcare professional now, which vaccine do you recommend? The first one that you get. The first one that's available, you get. I don't mind whether I'm going to line up for an Oxford AstraZeneca one. If it's 2 doses, that's fantastic. If it ends up being a Pfizer one, no problem. Moderna, no problem. Any vaccine you like. In fact, someone jokingly the other day said, well, I'll get one in the one arm and one in the other arm. And you know what? Actually, that's not a great idea, because the different vaccines are not designed to work in combination. One vaccine, same brand if you like, perfect, but don't mind which one you get, right? Alice says, is it advisable to vaccinate pregnant women, and at what stage? Great question. Pregnancy and or breastfeeding for that matter. So the manufacturer answer would be no safety data, right? That's what they have to say, because these vaccines have not been around for very long, and they've been rushed into phase 3 trials and into emergency use for good reason. So they haven't had the ability to be tested in all of the different patient subgroups, right? So the real answer is you would have a conversation, you, the doctor, would have a conversation with you, the pregnant patient, or you, the breastfeeding patient, and say, right, in real terms, what are the risks from this vaccine? What are the risks from getting COVID-19? And what are the upsides? What are the downsides? If I read the general advisories from Europe and the US, it would seem to me at the moment that most healthcare professionals are advising that it is safe to take the vaccine in both pregnancy and in breastfeeding mode, as long as you don't have any other contraindications to a vaccine. And therefore, most patients who are sort of under good information and getting decent feedback on the vaccine are taking the vaccine quite happily. Cool. Let's shoot down the list here. Tamoxifen users at higher illness fatality. Not that I'm aware of. I don't track a lot of specific tamoxifen user data, but in terms of mechanism of action, there's no real indication currently as to why that should present with a more severe disease group. Certainly not in terms of the fact that the disease predisposition, that's the disease of COVID-19, presents in any particular way from a lower respiratory infection. I'm sure data will come out over time as we track different patient subgroups, right? Cool, let's have a look down. If someone's already had COVID and they've recovered, can they still transmit the virus to other people? Having just been strapped, not present. Okay, cool. So yes and no is the answer there. What a frustrating answer. I'm sorry about that. So if you've had the infection, you've now likely got antibodies, right? So if you are exposed to a new set of antigen, a new virus, you are highly unlikely to develop infection, right? So you're highly unlikely to be able to pick it up, and therefore in that space, no, you therefore can't transmit it, right? So you become one of the herd immunity people, all right? Which is a great thing because it means you're no longer part of the problem, you're part of the solution. Cool. Is it completely impossible? No, because as we've demonstrated already, it is possible to get the infection more than once, okay? It's unusual, not common. You know, most people who've had it only have it once, but it is possible to get a second and even a third similar coronavirus infection. Why? Lord alone knows is probably the answer, but it probably relates to your own severity of infection first time around, what level of antibodies you may be produced, what was the challenge on your immune system first time around compared to second time versus third time. So, you know, in that scenario, you should, in my head, as the very simple doof doctor, once you've had it, your chances of getting it again go down by a whole bunch because you're definitely going to produce some antibodies. If you produce enough to ward off the evil spirits for a while, great, but it's not completely impossible. Right, so Cindy, I've had COVID. Do I need the vaccination? Sure, good question. Don't be scared of a vaccine. It's got nothing to do with whether you've had COVID-19 before or not. Number one, you know, it's almost like a double insurance policy, so that's a good thing. Number two is the vaccine strain is potentially slightly different to the COVID-19 that you had, so it will in fact be adding to your protection, number two. And number three, depending on when you had the infection and how severe the infection was, your own natural antibodies will be up or down relating to your starting point of your illness, right? So by having the vaccine now, you're really essentially having a booster and you are giving your immune system every single chance to fight the vaccine. So current teaching is even if you've had COVID-19, as long as you've recovered and you're not currently suffering from a viral infection, which is usually when we don't recommend any vaccine. It's not because vaccines aren't safe if you're sick, right? It's just because we can't see whether you're getting sick, staying sick, or whether unusually you're developing some kind of reaction to the vaccine. So it'd be nice to be able to monitor you. So generally we try and give the vaccine to people that don't have any other symptoms that'll confuse us. Why are younger, fitter, healthier people dying from COVID? Well, that's because more younger, fitter, healthier people are getting COVID. Ne? So it doesn't mean, and this is probably the basis of your question, it doesn't mean that the virus is now changing to a degree where it's capable of attacking younger people. The numbers actually tend to suggest that it's more a function of more and more and more people are being exposed to the virus. the virus is more transmissible in communities today than it was 6 months ago as a function of failed lockdowns, failed community breakages in transmission, 20-something-year-old parties. Social behavior drove a second wave of disease in younger people. And then ad ergo, some percentage of those people will get sick and a smaller percentage will die. So it doesn't mean that young people are now suddenly more susceptible, point one, and it certainly doesn't mean that the virus is more able to affect younger, fitter, healthier people. Nicole said something about a reference that she has from an oncologist suggesting no increased risks. Okay, cool. That's great to know. I'm not aware of the reference. I'm sure locally we'll get people to support that. And that goes with my sort of guesswork based on the same thing. So thanks very much for that one. Had the virus September, was ill, chest still bad, having physio, Not sure that there's a question in there, but just saying, okay, that's your current status. What it really suggests to me there is that you're still currently recovering from that particular infection. So you do need a regular consult with your healthcare professional, number one. And number two, if you've got those features at the moment, you wouldn't be a candidate right now for a vaccine, that's for sure. Okay. Karina asks if I haven't had enough, my other sip of coffee is still missing, hang on. So efficacy of the vaccine against the new strain, less, slightly, it would seem, and that's logical. That's not a vaccine failure. It's just that vaccines are mapped in a laboratory against a specific strain. Okay, it's no different to the flu vaccine, right? So as viruses mutate, which is normal, viruses mutate because that's one of their survival and ongoing infection mechanisms, right? So as they mutate and create new strains, version 1, version 2, version 3, those strains are subtly different from the first one. There will always be some cross-reactivity, some cross-effectiveness of antibodies between strains until the difference between two strains is big enough so that the antibodies against the first one don't work against the antibodies, don't work against the viral infection of the second one. Cool. Now, currently, it seems that the vaccines are pretty effective against all the strains. They seem to be slightly less effective against the newer strains, the so-called second and third versions, the South African variant. You got to love it, the fact they name it South African variant. This is because we happened to find one of the versions first, right? We didn't specifically create a variant in South Africa. And it's popped up all over the world. So there are a couple of versions. It's logical that the original vaccines won't be as effective against the newer versions in the same way as the flu vaccine. And what will happen is, because we now have a lab map, a blueprint for vaccine 1, the next vaccine can be adjusted to be successful against the next couple of strains, right? So as those vaccines go into production, they will be produced to target the common strains that are floating around in our communities, right? In exactly the same way as the flu vaccine that you take now, coming up in March, April, the autumn flu vaccine, which everyone should be taking, by the way. That flu vaccine is mapped against the 3 strains of flu virus that were most commonly found in the Southern Hemisphere in the last 12 months, right? So that vaccine is perfect against what we call old flu, but it's no use against new flu, or what we actually call wild flu. And wild flu is really the mutated strains of flu through the course of this season. So that'll emerge, and then next year's vaccines will tackle those. Physicians recommending flu vaccines coming up now, asks Patricia, not that you necessarily won't get COVID, but right. Okay, so yeah, I always recommend take the flu vaccine whenever it becomes available, right? So if we're starting to get 2021, I haven't actually seen whether they've arrived yet. I speak under correction. So if they're starting to arrive, great. Normally they don't arrive quite now. This is a little early for the flu vaccines, but when they pitch up, sure. Then take the 2021 vaccine. There's no point in taking the 2020 vaccine now, because you're gonna be chasing old viruses, right? and you're certainly not going to be doing much traveling, so there's no point in taking the Northern Hemisphere vaccine either. So the wait for the 2021 Southern Hemisphere vaccine for flu. And the other part of Patricia's question, you won't get COVID, but will have less severe symptoms, illness. Yes, there is some logic in that. The logic being, number one, you don't want to get flu, right? Because flu is just not a nice condition to get, point one. Point two is some of the symptoms of flu are certainly the same as COVID-19. So getting flu will be a confounder. It just makes the diagnosis more difficult. It makes it more tricky to decide whether you're sick with COVID or sick with flu. So if we can take flu off the table by keeping you vaccinated, fantastic. So yeah, don't be shy to get it. Cindy's question, how long after having COVID can I be vaccinated? Strictly speaking, as soon as you're not symptomatic anymore, really. So as soon as you're not symptomatic from your original viral infection, in other words, you are clinically well, okay? You don't have to specifically test negative, point one. You don't have to test for antibodies either. But if you're clinically well and like up on your feet, back at work type of situation, then by all means, you are safe enough to take the vaccine. Cool, let's just see here. Alice is asking, will medical aid companies be involved in the procurement of vaccines? Probably, not yet, just because currently the only buyer is government. So currently the South African government is the buyer or procurer of the vaccines coming into South Africa, and all of the other parties, hospital groups, medical insurers, etc., will buy secondarily from the government, right? So they'll be the second purchases, and then they will assist in distributing to their various healthcare worker populations, members, whoever. You would anticipate that once the vaccines are more available, once vaccine procurement for South Africa becomes easier, largely because of global supply, and there's a huge amount of competition globally right now for everyone wants to get their hands on vaccines, right? So currently it's a supply-demand thing. There's more demand than there is supply. Once the supply improves a little bit, I'm fairly sure we'll see hospitals, medical insurers, etc., being able to procure vaccines directly, like we do with all the other drugs that we buy from around the world. And then we'll go into a situation of sort of more normal. But currently, no, is the answer to that question. All right, around medical aids. There's a sort of a secondary question around medical aids around payment for vaccines, by the way. And it would seem at the moment that there should be no problem with that. So medical insurers are quite happy to pay for the vaccines for you as a member. If you're a healthcare worker, for example, your medical insurer will pay for you to get the vaccine. That's not an issue. They're not likely to be ridiculously expensive though anyway. So vaccine is not traditionally an expensive medication compared to all the other expensive things that people sometimes require. Vaccines are not hugely expensive for individuals, but insurers are certainly looking at reimbursing for those vaccines, point one. And a lot of it will just wait until we've actually got enough supply. And the supply really is the key issue. You would have seen in the news that a number of countries are putting huge pressure on the vaccine producers, the pharmaceutical companies like the Pfizers and the AstraZenecas and the Modernas of the world. Those are just the big three that I can think of. And appreciate that they are under huge pressure to produce quantities of these vaccines. So I'm actually quite supportive of the effort that these companies have gone through. You don't often hear doctors being very supportive of big pharma, right? But I think they've done a fabulous job now in terms of just the speed with which these vast quantities of vaccines have already been made available. And I think that can only be a good thing, and that's a success story. So, you know, if you look normally how long it takes to stretch production from original R&D of vaccines, they've done a great job. Antibody tests being not particularly accurate. Yeah, they're not 100% accurate, that's for starters. So antibody tests range, it depends on the test as to how accurate they are. And they can range anywhere between, you know, as low sub 40s for some of the tests to north of 85 for some of the tests. It really is like any other test. You know, whether it's a malaria test or a test for rickettsia for tick bite fever, or a test for coronavirus. You have to weigh up the need for the positive result, what you're going to do with that result, and how accurate the test is in the context of, am I clinically sick? Right? So if the person's sick, we're going to use the test to confirm or corroborate the clinical suspicion that they're sick with that virus, right? If the test is negative and the person is still clinically sick, then the healthcare professional has to make a call on, am I now going to assess the test as being wrong, or do I need to go and test for something else, right? So we have that debate all the time in medicine. It's not unique to coronavirus or to COVID testing. If you've traveled to the Kruger National Park and you come back and you have a fever and you're sick and you've got a headache and I do a malaria test and the test is negative, that doesn't mean you don't have malaria, right? It just means that the test didn't happen to come back as positive for malaria. I now have to make a judgment call on, could this test be wrong? Could I have missed the sequence in the body when the test was most sensitive? And all of those are yes. So then I have to still make a call and say, right, you know what? Clinically, it still looks like malaria. So we're actually going to treat you for malaria. Or maybe we're going to just test you again and see, right? So the same logic will apply. Cool. Non-vaxxed person, Louise asked a great question. One of those non-vaxxers out in the general community, can we demand that they get vaccinated? You know, line them all up, right? All of you that have got a vaccine, you can come in. All the ones that don't have a vaccine, sorry, you're staying in the parking lot or you go home. Eh? Huh. I don't think we're quite there, although it does sound quite attractive, I suppose. Currently, the way, let's start with the law, okay? So the law can't mandate that anyone has a vaccine. So if you don't have a vaccine, you don't have a vaccine. It's a choice thing, right? Point one. Can you encourage people to have a vaccine? Absolutely. Can you discriminate against people that haven't had a vaccine? No, you can't do that. That's not so cool, and we're not going to recommend that either. Can you create work situations where people have to be vaccinated? Okay, that starts getting quite testy. Okay, so could a company insist on a vaccine? The real answer is no, although some companies will try. Okay, and it will have to be tested in law. Now, I'm not a legal person, but I can see a lot of cases coming where there will be a lot of tests around employment law as to what mandates a safe working environment. The real test is to take COVID off the table and compare it to something else, right? So does your work mandate that you have a measles vaccine? No, they don't. But when your child goes to school, they ask for your vaccine card to check that your child has had a measles vaccine, right? And then if you decided that you didn't want to vaccinate your child for whatever reason, but we're not talking to you, whoever you are out there, by the way, but then you would have to have some argument with the school and you'd have to prove why, and there'd be a whole lot of hoo-ha, and then eventually the kid would go to school, right? But it would be a lot easier just to have a vaccine card and prove that you had the vaccine, right? So the same kind of thing's probably going to creep in with COVID. Initially, it'll be a choice thing, and more and more and more, it'll be sort of recommended. But I can't see that it'll be a demand just yet, as nice as that would be. In the healthcare world, they're going to ask a few extra questions, just to wrap up on Louise's question. You know, so as a healthcare worker, you can't work in an obstetric environment unless you can prove that you've had a hepatitis B vaccine and a rubella, German measles vaccine. Okay, prove. Okay, at medical school, which was a long time ago for me, I couldn't go through 4th year without proving that I'd had those vaccines. Finished. It was just like an accepted norm. So it's already there for other viral infections. So logic says that if the world perceives COVID-19 as a significant risk to patients in a hospital environment, then certainly health professions councils of the world may start recommending that all healthcare professionals have to have the vaccine. We're not there yet by any stretch of the imagination, probably just because everything's moving so fast, right? So we're still trying to get the vaccine, and we're still trying to get people well, and we're still trying to get the community under control. So no one's had time yet to figure out the regulations of who must or who mustn't have the vaccine. Cool. Time frame between vaccine, flu vaccine, is it roughly at the same time? So if I'm reading the question correctly, should there be a time window between taking the vaccines, or can you take them at the same time? Generally speaking, you know, there's two schools of thought there to give you the answer. Again, because I'm not a vaccine. I don't know why we're all talking about vaccines. I'm the emergency guy. If someone could just have like an allergic reaction or a heart attack or something, that would be far easier. And then I can talk to you about how to manage those. Or if you stub your toe or slam your fingernail in the drawer. Okay, but seeing as though vaccines are the thing, let's see how we can help. So in situations where it's difficult to get access to the patient, so we think about rural communities, people where we may be doing circulating vaccine treatments, very often we bomb a whole lot of vaccines into a child all at the same time. No problem whatsoever. Okay, so in the real world, we dish out lots of vaccines all at the same time because it's a good opportunity to try and get maximum protection, right? Is there some logic in spreading certain vaccines apart, like a flu vaccine and a COVID vaccine? Sure, only because we'd like to see if there is any small effect relating to the taking of the vaccine, right? Because we don't have a lot of experience with a COVID vaccine. So it would be nice to get the COVID vaccine, and then if there is going to be some kind of reaction afterwards, which is extremely unlikely, by the way, it would be nice to be able to blame the reaction on the right thing, okay, not confuse it with another vaccine. That's really the only logic. Incidentally, the risk of a reaction, like an allergic reaction or something else, to a vaccine, like a COVID-19 vaccine or any of the other viral vaccines, is pretty small. Hey, we're talking about like 1 in a million, give or take. Okay, 1 in a million chances, which is like tiny. You've probably got almost as much chance of winning the lottery. Okay. Let's see here. Do supplements like zinc, vitamin D, vitamin C help immunity? Yo, right now, great question. Hey, those are all good things. Okay, so zinc has definitely got a link to immune system health. So most practitioners will recommend zinc as a supplement. If you're not getting enough in your diet, then taking supplementary zinc has been shown to certainly decrease severity of viral infections in the same way that vitamin C does. They're not well retained as minerals. I mean, vitamin C is not a mineral that your body retains very well at all. So ascorbic acid, again, a lot of it is diet, you know, so some people are supplement poppers and some aren't, right? And a lot of it translates to how balanced your diet is and what you take in through the course of your diet, and also how much your body can retain. So you can't mega dose a lot of these substances. All you're going to do is pee them out, right? Your body can't absorb things in industrial quantities. So thinking that I'm going to take 3 because it's better than 2 is very seldom good medical logic. But certainly there's good data to support zinc in fighting viral infections generally. Does it have any impact on COVID-19 specifically? Not a clue, but logically says it should help a little bit just because it's a virus. Ne? And the same applies to vitamin D. Vitamin D is also a very useful immune boosting vitamin. A lot of its functionality talks to immune function, and even patients, current COVID-19 patients in hospital, are getting supplementary vitamin D as part of the treatment regime that we use for COVID-19. So all good stuff, all good stuff. I see Nicole's posted a useful reference there from one of the legal firms, employment about imposing. Good, go and have a read of that. I can't tell you what's in it, but certainly there's going to be some challenges, I think. The real answer is that employers will try and do it for the so-called safety of everyone else, and then there'll be a whole bunch of right to refuse, right to take, right to safe working environments, right to protect yourself, right, blah, blah, blah. And all of those rights will be valid, and some of them will be in conflict with another one, and the smart legal people are going to have to fight it out, I think, is the real answer. If you've had a vaccine a couple of years ago, should you have the current flu? Now, are we talking Mrna vaccine? Okay, so I'm not sure, Wendy, if your question is you had the pneumococcal vaccine, which is against a different infection, okay? In which case, by all means, take the flu vaccine. No problem. They're fighting different infections, right? So just bomb them all on board, happy days. If your question was, I had a previous flu vaccine, and now should I take the current flu vaccine? Yes, as well. The answer to both is yes, because the current flu vaccine is certainly going to be more up to date in terms of current strains of flu that are perambulating about the community. Patricia's question around the doses of those supplements, I can't answer that because I'm not a nutrition dose expert. And the real answer is it probably depends on what you need as an individual, what your actual diet looks like in terms of supplements. And generally speaking, for me as the kind of common sense type diet person, I tend to take things in very small doses, if at all, mostly because I think my diet is pretty well balanced, right? So I'm far more likely to go for the extra portion of fruit and veg and skip the bad lifestyle habits that kill some of those substances, as opposed to grabbing for the pill that is going to simply make me a lazy eater. Okay, so recommended doses, I don't really have a good answer. Chat to a nutritional expert by all means, but just have a healthy amount of common sense in play before you attach, shall we say, magic bullet reputations to any of the supplements. Just take them to help boost your general immunity and get sensible advice around the quantities. Cool. I've shimmied down to the end of those questions. I'm just going to scan back here to see if I've missed any obvious ones. I missed Nicole's about the pop-up stations, rapid testing stations. Yeah, is it an idea to get one a waste of money? The answer is it's not a waste of money. The answer is, what do you need the answer for? Okay, so if the hospital needs you to have a negative test to go into hospital for another procedure, well, they're not going to accept a rapid test anyway because you need a PCR test, right? So if you want to get on an airline to travel to another country, they're going to need a PCR test. And not that we can get on an airline now to travel anywhere. So we're stuck at home. Ne? So the real answer is, what is that question going to answer for you as the individual? If it's for pure academic curiosity, you want to know, I'm sure I had COVID and I can't quite decide if I had it. It would be mildly interesting to know whether I had it. By all means, go and get a rapid test. But it's not going to help you specifically in terms of formal treatment. So I think the real answer is, what question are you trying to answer? And then you can pick the test that's necessary, right? I see we've got a couple of messages just lurking at the bottom. Better question. Someone says, you've got COVID. At what point do they need help or go to emergency unit? Okay. I don't use the word casualty just because I'm like picky as an emergency guy. You know, casualties for casual doctors, emergency units for like emergency doctors, right? But that's just semantics. Okay. So also casualty derives from an old military term, because you were a casualty if you were injured, right, or you had a wound. Okay. And COVID's not one of those. So you go into the emergency unit. If you're in Cape Town, you go to emergency center, because the Western Cape people label things differently just because they're special in their time zone, right? Right, so when do you go? Okay, so number one, this person says that you've got COVID, right? So you've already had a test, okay? So you've already, therefore, you would have had the test because of either some other procedure or you had symptoms. At what point do you need help? Well, when your symptoms become challenging to the point of either you are distressed from a shortness of breath, persistence in fever, persistence in the other symptoms related to COVID, the muscle weakness, gastrointestinal upset, generally not feeling well, the malaise. Essentially, it's the same transition to you as a sort of a lay patient when your cold starts feeling a bit more like flu, okay? And that's a common sense decision, okay? When your cold is manageable at home, you can sleep, you can control your temperature with a little bit of paracetamol, and you feel better if you have Granny's chicken soup, then you don't need to go to hospital, right? If those things are not working, or if your level of debilitation is you can't get your head off the pillow, or you're feeling particularly crummy, well, then that's when you need a healthcare assessment. What you can do, because hospitals and healthcare environments now are a bit intimidating with the COVID story, see if you can find a telephone solution. Maybe phone your general practitioner, you know, get a little bit of a telehealth solution from your GP. They'll be more than happy to chat to you and say, right, here's the symptoms I've got. Yes, that sounds a little bit like we'd like to evaluate you. But at the end of the day, if you really are concerned and you can't answer the question for yourself, go to the emergency unit is the basic answer. And then we can help you make the decision. Do I have figures on idea how many doctors, nurses, healthcare workers died in COVID? Yes, I do have lots of those numbers. A lot is the real answer. Okay, we're talking, and I can't put the finger on the stat right now just because that's not up in front of my screen. But you know, just in different hospital groups, we've had hundreds of healthcare worker deaths in South Africa. Okay, so we're not talking 5 or 10, we're talking hundreds. Nurses, doctors, allied healthcare workers. not a day goes past where one of the hospital groups doesn't share a message with someone else around, please spare a thought for sister so-and-so who was working in ICU at hospital X in the country who died from COVID-19. So it is a reality right now that healthcare workers are exposed. They're genuinely on the front line in terms of higher risk exposure. It's not because they're going to get disease more serious, it's because they're exposed to COVID all the time, right? So they've just got more chance of getting it today, tomorrow, and the next day. So the sooner we can get that vaccine on board, the better. Last question maybe, because I see we've run out of time. Oxygen meters, essentially what we're talking about there is pulse oximeters, the ability to measure oxygen saturation in a home or domestic or even emergency environment. Yeah, they're quite useful to us clinically because it helps give us a measure. It's like a vital sign. It's like measuring blood pressure, right? So measuring oxygen saturation is one of the clues of a person going into a degree of respiratory failure. It's not the only clue, and the test is not bulletproof. So if you are an anxious Nelly at home and you do need to monitor these things, having a pulse oximeter is not a bad thing, but you should have a medical professional that you can phone with the number so that you don't get yourself into a panic and watch the number obsessively while you're sitting there, because that's not really going to help you. Cool. We have shot through a whole raft of questions. We are, I think, sort of up to the end of our time. Louise, general organizers, I hope that ticked the box of usefulness for a bunch of you. I hope that was sort of vaguely helpful for your Saturday morning. And you got a little bit, I think the questions sort of warmed up as we got there. And they kind of focused everyone's interest. I think there's certainly a lot of material shooting around both vaccines, COVID-19. Just keep reading, utilize the different websites. The one that I recommend for most people locally is the website of the NICD, the National Institute of Communicable Diseases. That's kind of our CDC equivalent, right? And the website is very useful. It's got a healthcare worker section on. It's got a normal people, us people section on that doesn't use like all sorts of confusing words, and very helpful to get current data on what's cooking with COVID-19 and other stuff. Right. And I think that should just about cover it. So I'm not sure if anyone else needs to conclude, but I'm going to sign off and head for my coffee machine as fast as I can, because I made the mistake of putting my laptop just too far from the espresso.
Thank you very, very much for joining us this morning, Charl. I think it was really nice to have kind of a complete outsider to answer some of our questions this morning. So thank you very much. I think it's been very useful.
Most welcome. Most welcome.
Thanks.
Okay, cool.
Charl,
Chat next time.
thanks for taking your time out of a Saturday morning. I know weekends are precious to all of us. And I think from myself and the rest of the team, I've learned a lot. It's not always you can ask our cancer doctors any of these questions, because the reality is they're not fully aware of what is going on in the greater community. So, Charl, thank you very much. Appreciate your time this morning. And we'll see you soon.
See you soon. Chat soon. Give me a shout when you've got another topic to chat about. Huh?
We will definitely. Thank you. Okay, ladies, do you guys want to have a bit of an interaction amongst each other and chat? You're welcome to.
Yeah, thank you to everyone that's joined us today. We had a really, really nice group of ladies. I think for now, we're going to keep our Bosom Buddy meetings online. We were hoping to start physical meetings again this year, but then second wave came and hit us, and we would rather be safe and keep us all safe. So for now, we're going to carry on with our virtual meetings, and I have sent out dates for the rest of our Bosom Buddy meetings for the year. They are on Facebook. If you're curious, let me know, and I'll send them out. We're hoping from our next Bosom Buddies meeting to have a bit of a different registration process. So you can just go onto our website and pop in your email address, and then you'll be registered for the webinar. So just to let you know, next time might be a little bit different, but it's all kind of in the testing phases now. Might be a little bit easier. And if you have any suggestions for speakers or want to hear from any speakers in particular this year, we're open to suggestions, and also open to suggestions for anything you'd like from our virtual meetings this year. Then absolutely let us know. What we are going to start is for our metastatic ladies, we will have a Thursday Metabuddies metastatic breast cancer support group specifically geared at our metastatic ladies. And I think that will be really, really nice and interesting for you. And we'll get speakers and topics that's specifically relevant to you. So if you've got any suggestions for speakers or anything like that, then let us know and we can plan that for our Thursday afternoons. Okay.
Okay, just for Jen, thank you. If I didn't have my millennial in the office, we would be very lost without all the technology and what she's doing on the website and online entries, etc., etc. So thanks, Jen, for all the hard work you put in. And just as a FYI, this is the Charl that always gets referred to, if you haven't figured it out yet. Okay. So thanks, everybody. Nice to see the faces around. Nice that you all around and staying safe and away from all those shops and things. Jen, did you give everybody the rundown on what's happening in the clinic?
No.
Okay, so what we've been doing, Carol and I, we've been doing Ben Bits every Monday morning and just recording short videos as we progress through this lockdown on what you should and shouldn't be doing as a patient. So I'm just going to run through it very quickly. If you're not sick, don't go to a hospital. If you're going for your annual checkups, it can wait till level 1. Okay, it's not, a month or 2 months is not going to make a difference. The idea is to not get you exposed to hospitals and to large communities that you don't know if they've had COVID or not. So unless you have a breast emergency, which most of us are post-treatment now, stay away. Okay, don't book your mammogram now, wait a couple of weeks. Don't go for your bloods now, wait a couple of weeks. Only if you're symptomatic, go. And the best advice for all of us is protect yourself, clean hands, masks, etc., and avoid the shops, because that's more than likely where you're going to pick it up. Okay, so stay safe. I know it's not always great to have to isolate and not see everybody, but I think this is the way to do it. And we've just all got to stay safe. One of my teams had COVID in December. You can read my story in Buddies. And she's a month post-COVID and she still has a cough. So her chest is still taking strain. So COVID isn't just those 2 weeks. She's not contagious, but there are definitely side effects post getting better. So just stay safe, sanitize, avoid crowds, don't come to the breast clinic unless you desperately have to, and look after yourself. Thanks, everyone.
Look after yourself as well, both of you. Thank you so much for all that you do.
Thank you, Anthony. Thank you.
It's an absolute pleasure.
Yes. And it's so great to see everyone's faces.
I was joking about it with a colleague the other day. I'm hitting 15 years, Antoinette, and so are you, as a buddy. It's a lifetime. But we're still here and we'll keep going as long as we can.
For sure.
Yeah.
Great.
Bye-bye, everybody.
Bye-bye, everybody. Thank you
Bye,
very much, ladies.
Please have a
Bye.
good Saturday.
Bye.
Love to all. Thank you.
Bye.
You too.
Bye.
Bye-bye.
Jane.